Hello, good evening, everybody. Please confirm you can hear me on the chat, please. Okay, so thank you. While we wait for Prof to join, everybody has been muted. So we're trying to get the class a little bit organized today. So towards the time we'll ask questions, we'll unmute anyone that wants to ask a question. You have to raise your hand and you'll be unmuted. So thank you. Okay, so once again, good evening, everybody. I just spoke with the prof. He will be joining in 2 minutes. Thank you.
Good evening, everyone, and welcome. If you can hear me, show by raising your hand, and that will get by typing yes in your chat box so that I know you can hear me. All right, that's great. Okay, thank you very much. So we are going to commence from the topic we are going to look at. Today we are going to look at the tools we use in measuring outcomes in epidemiology. The tools we use in measuring disease outcomes or indicators in epidemiology. Okay, so let's go. Health is one of those terms which most people find difficult to define. Many people define health differently based on their own understanding and perception or perspective. So it does vary. However, WHO came together. WHO was formed immediately after the Second World War. When the Second World War ended in 1945, then countries came together, Committee of Nations, and formed the WHO. So WHO came together and tried to define health and gave the definition that health is a state of complete physical, mental, and social well-being, and not merely the absence of a disease or infirmity. However, this statement has been amplified in recent times. Okay, in order to have positive health, people are expected to have socially and economically productive life, right? Even at that, a lot of other ones have tried to modify the definition. Okay, modify the definition, but in essence, the WHO definition has actually not changed. There have been many vistas to it, some talking about spiritual health, emotional health, vocational health, and political health. These are various dimensions of which, of course, they all affect health one way or the other. But the main definition about a complete complete physical, mental, and social well-being, and not merely the absence of disease, still stands. Modification has not taken place. Yesterday, we talked about spectrum of disease and this the history of disease, right? We talked about spectrum of disease and the history of disease, the continuum of the disease. So we talked about it's a wide spectrum, okay? The spectrum of disease is actually wide, from optimal health to when the disease manifests severity and death, of course. Okay, so that is just that. So history of disease is an outcome. However, there have been attempts to define disease. WHO defined health, but WHO has not defined disease. Okay, WHO has not defined disease because disease too has its own confusion. Several other people have tried to define it. Like if you go to the Webster Dictionary, it defines disease as a condition in which the body health is impaired, a departure from a state of health, an alteration of the human body, interrupting the performance of vital functions. While Oxford Dictionary defines disease as a condition of the body or some part or organ of the body in which its functions are disrupted or deranged. Then there are other definitions. Some definitions, looking from the ecological point of view, define disease as a maladjustment of the human organism to the environment. That when somebody is not well adjusted to the environment, and that constitutes disease. Okay, so because of the confusion about disease, because of the confusion about disease, it has remained the way it is the present day. It is not, you see here I have been put that WHO has defined health but not disease. And this is because disease has many shades. And that many shades is what we call the spectrum of disease. And it ranges from inapparent forms of disease, those subclinical forms or abortive forms, to severe manifestation of the illness itself, leading to complications. Okay, some diseases can occur acutely. Others are insidiously and occur chronically. Okay, examples, food poisoning, gastroenteritis, that is stooling and vomiting. Those diseases can occur. Some of them occur in hours. Okay, in 1 hour and 2 hours, they can occur. And people, but other diseases can take such a long time and so gradual, and it's become unnoticed until its full manifestation, like mental illness, rheumatoid arthritis. They are very gradual. They creep in very slowly. So diseases vary. Then in some cases, there are carrier states. We talk about it severally, where there are no individual manifestation of signs and symptoms. Outwardly, the person looks healthy, but inwardly, the person has a disease that is even transmitting to other people. In some instances, one organism, okay, can cause different, sometimes many organisms can cause one manifestation type of disease, and sometimes one organism can cause different manifestation of disease, like diarrhea, for instance. Because more than one, it can be caused by more than one organism. Diarrhea can be caused by more than one organism. Different viruses, parvovirus, rotavirus, dysentery, or different organisms can cause diarrhea. Okay, so that is why disease can be somehow confusing. Okay, so it is easy to determine illness when the signs and symptoms are clear, are obvious. But in many diseases, they are not as obvious. We see a lot of borderline cases like diabetes. We might find what we call pre-diabetes or pre-hypertension. We will not say clearly that this is hypertensive for now or not. But the issue is that such cases might manifest differently later in life. So that is it, right? Sorry. So they can manifest differently. So that is part of the problem with disease. Okay, so what tools do we use to measure diseases and health? For instance, as epidemiologists, we express diseases in terms of rates, ratios, and proportions. And these three mean different things. They mean different things. Some of you who are healthcare workers, you will notice them, then you'll begin to see why they are different. Okay, why they are different. Okay, so we'll see it. Now we'll look at what rates are. Okay, look at a rate measures the occurrence of some particular events. That is like development of disease or occurrence of death in a defined population during a given period of time or during a given period. A rate comprises the following elements. It has a numerator, it has a denominator. Then a rate also has time specification and a multiplier. The time dimension is usually the calendar year. We usually use the calendar year like death rate per annum, birth rate per annum. That's a time specification. In epidemiology, a rate is a measure of the frequency with which an event occurs in a defined population over a specific period of time. So let us see a typical example of a rate. It is expressed per thousand or other round figures, maybe like per 10,000 or 100,000 or a million. Okay, these ones are selected according to the convenience of the individual. Okay, because round figures, maybe death rate will talk about the number of deaths over the media population times 100 per year. It can be times 1,000 per year. It can be times 10,000 per year, depending on how you want to express it. But the important thing is that they should be round numbers, not per 104 or per 1,005. No, it's not like that. It should be like that. Okay, so we have different rates. Okay, let me tell you more about rates, for instance. You see, in a rate, the numerator, here we say that a rate has a numerator, it has a denominator, then the multiplier, then the time specification. So in a rate, the numerator is part of the denominator. In a rate, the numerator is part of the denominator. How do I mean? If we say death rate, a river state, for instance, we are saying all the people who died in river state in 1 year, over 1 year, over a period of 1 year, over the media population of river state. That's the crude death rate. Now, what is said here is that all those people who died are part of that population. That is, the numerator are part of the denominator. Okay, so all those that died from the overall. It's just like when you say in a class of 30 students, how many passed the exam? Maybe 25 passed the exam. So the rate of pass is 25 over 30. That 25 that passed the exam also are members of the class. They are part of that 30. So in a class, a class of 30 persons, 25 pass the exams. So the pass rate is 25 over 30, times 100. That is if you are using 100%. Percent means per 100. So that is why rate is. So when you are talking about rate here, the numerator is part of the denominator. I want to bring this out because when we go to ratio, the numerator is not part of the denominator in a ratio. So as we go, you see it. And here, we talk about the media population. The reason we say the media population is that population is dynamic. Population is not static. There is in-migration. There is emigration. People are dying. People are being born. People are traveling out. People are traveling in. You see, so population is a little bit dynamic. It is not stable. That fluctuation might not be very serious in terms of numbers, but it is not exactly static. So because of that characteristics of population that makes it, vary, by convention, it's now decided that let us take the mid-year population as the population for that year. Because the population in October might be different from the population in May, might be different from that of February, might be different from that of December. So, but again, when you look at it, as people go out, people come in. As people immigrate, people immigrate. As people are dying, people are being born. So if you plus and minus, you find out that the variation is not much, right? So it's fairly stable, but it's not exactly the same. It was now adopted by convention that media population is the population as at 1st of July every year. The population as at 1st of July is the media population. All right, I believe that is clear. So there are categories of rates. When we talk about rates, we have crude rates, we have specific rates, we have standardized rates. Okay? Crude rates are just the general type of rates. We do not rely so much on crude rates because it has a lot of disadvantages, but they are not useless anyway. They are not, it's not as if we don't use them. So these are the actual observed rates. Crude rates are the actual observed rates, such as birth rate, death rates. Crude rate also known as unstandardized rates. So they are unstandardized. Death rate in a place, birth rate in a place. Well, we use them, but it has a lot of limitation. I will tell you why. As we go on, you will understand better. Then we have specific rates. Specific rates are better. Specific rates, these are actual observed rates due to specific causes. Maybe death rate due to TB, death rate occurring between sexes, age and sex, death rates that occur maybe annual death rates, they are specific for those months or weeks, death rates due to particular disease, death rate among particular age group. So these are specific rates. They are more useful in epidemiological terms. But crude rates, we also use crude rates for planning. Then we have the standardized rates. Standardized rates, when we now want to make more sense out of the crude rate, we go ahead to standardize the rate. Standardization simply means an adjustment. Okay? Those adjustments are, if you don't do those adjustments, it becomes difficult to at times use crude rates comparison. For instance, if crude rate in River State is 15 per 100,000 per year, and crude rates in Abia State, for instance, is 12 per 100,000 per year, right? Crude rates. Mere looking at those figures, you can erroneously jump into a conclusion that crude rate is higher in River State than in Abia State. I mean, you can just say death rate is higher in Abia State than, in River State than in Abia State, simply because you saw 15 per 100,000 per year, and here you saw 12 per 100,000 per year. You see, if you make such conclusion, you might be wrong because they are unstandardized rates. If you want the real you go ahead to standardize those rates. And when you standardize those rates, then it will now be clear to you to actually know if truly there are more death rates in rivers compared to Abia. You might be shocked that when you standardize the rate, there will be more death rates in Abia than in rivers. That is why crude rates are just those rates you observe. And in epidemiology, we don't make much use of it, okay, because it has some shortfalls. Then ratios. Ratios expresses a relationship in size between two random quantities. A is to B, C is to D. Those are ratios. In ratio, the numerator is not a component part of the denominator. Unlike in a rate, the numerator is not part of the denominator. Then the numerator and denominator may involve an interval of time or maybe instantaneous in time. So broadly speaking, you can express rates the way we have seen it, x is to y or x over y, okay? You see, so now let's go, you understand better as we go. So take, for instance, the number of children with scabies at a certain time in a state, for instance, over the total number of children with malnutrition at a certain time. You see, here we are talking about the numerator, we are talking about scabies, and the denominator, we are talking about malnutrition. You see, take the second and say the ratio of white blood cell relative to red blood cell is 1:600, which means for every one white blood cell, there is 600 red cells. Okay? For every one white blood cell, there is 600 red blood cell. So that is the ratio, 1:600. Other example you would have come across in literature was, age-sex ratio, doctor population ratio, that is how many doctors per population, nurse population ratio, child-woman ratio, okay? That is the way it's expressed. So we can know how many children, for instance, the child-woman ratio to a children in a woman. So that is when we say, or health facility population ratio, how many health facility to serve a particular population. So we have so many of those ratios, but I will give you concrete examples as we go down. For instance, now for ratio, okay, let me just say for ratio, have maternal mortality ratio. You would have heard about it. And maternal mortality ratio is talking about the number of deaths of women during child and other puerperal conditions, okay, over the number of live births. Here we are talking about a number of deaths over live births. So that is a ratio. But maternal mortality rate is talking about deaths of women, right, among women of reproductive age. You see, so in the rate, the death of those women are also part of the women in that reproductive age. So maternal mortality rate is there, and maternal mortality ratio is there. So that's the rates and ratio we're talking about. And there are many other examples. Then we have proportions. Proportions are similar to rates. Proportions are similar to rates. But the only difference is that in a proportion, there is no time specification. Proportion is exactly the same thing as a rate, except there is no time specification. If you remember a rate, I told you that you have the numerator, you have the denominator, you have a multiplier, and a time specification. But in a proportion, you have the numerator, which is also part of the denominator, like in rates. Now you have a multiplier, but there is no time specification. That is the rate. So you can have proportion of children with scabies in a village. Proportion of children with scabies in a village. So that can be this is not per year. Okay, it's not, there is no per year in proportion, unlike in rate. So that time specification is not there. So that is the first one. Now, the second lecture, I'm now going to give you specific examples of all these things we have said now. So let's go. Let me share my screen. Then I'll... Oh, okay. Okay, sorry. So, all right. So this is where we are going to use this as we go. So morbidity, we are going to define some terms we use also. Some of you are familiar with them, or somehow you would have heard about them. We talk about whenever we talk about morbidity, we are talking about departure from health, sickness, ill health. And when we are talking about mortality, we're talking about deaths. Okay, morbidity is or any departure. That departure might be objective or subjective. If it is subjective, we really can't pinpoint on it. Somebody can say that I'm feeling as if something is crawling all over my body. That is a very subjective, because there is no way you, the practitioner, can find out what is crawling in the person's body. It's a subjective feeling. Most times we're subjected to neurosis. But you can have objective departure. Somebody is running temperature. All right. You can measure and see that the temperature is beyond normal, is above normal. Or somebody is hypertensive. You can measure and find out that the blood pressure is raised. So that is objective. So any departure, be it subjective or objective, from the state of physiological well-being is called morbidity. So the time is used as equivalent to times such as sickness, illness or disability, like that. So morbidity could be measured in three ways. That persons who are ill, or illness episodes, or duration of illness. So if the persons are ill, okay, 10 persons are ill. So we say there are 10 morbid conditions. Okay, it can be illness episodes. Illness episodes can be repetition of maybe bouts of spells of diarrhea, for instance. Somebody can come with the same person, and repeatedly, after a while, you have diarrhea every month, you become, or cough. So illness, these are episodes of illness in that same person's over time. And the other way we measure it is the duration. Some can be in days, some can be in weeks, in months, or even some sicknesses be in years. So sicknesses can be measured in years, in duration, or by episodes of it, or by the number. So that's how we measure the disease. So three aspects of morbidity that we commonly measure are the frequency, okay, the duration, and the severity. For the frequency of morbidity, we use the disease incidence and disease prevalence. These are also very common terms most of us would have heard of. These are also very common terms most of us would have heard of. Disease incidence and disease prevalence. What do they measure? They measure frequency of disease. They measure frequency of disease. Okay? Now, as we go on, where the average duration per se of a case, okay, so we use that to measure frequency, incidence, and then for duration, we just use the period, okay, the period of disability. The disability here does not mean, the strict definition of disability. If somebody is ill and is unable to go to school, okay, that is a disability because it's on sick leave or you're unable to go to work. So the person has disability for maybe 1 week or maybe for 3 days. It doesn't mean that it's a permanent something, the way we see people by the street, disabled, no. Yeah, so disability rate here in terms of, that's average duration of period the person is unable to go to school or go to work. That is that, okay? Then severity, we use case fatality index or case fatality rate to measure severity of disease. Severity of disease is simply talking about how fatal the ability of the disease to kill as many people who contracted that disease. That is why we use case fatality. If 100 persons contracted the disease and 15 dies from it, then we say the case fatality rate of that disease is 15 over 100. That is 15%, 15% at the case fatality rate. So some diseases have very high case fatality rates. Some diseases have very low case fatality rate. Okay, some diseases have very low case fatality rate. Then measuring disease frequency. These incidence and prevalence are the most commonly used ones. So incidence is telling us many times people just use it as English language. No, they are technical terms. They do not mean the same thing. Disease incidence rate is the number of new cases of the disease occurring in that population over a specific period of time. Incidents are new cases of disease that are observed over a period of time. Okay, so the number is the formula is the number of new cases of any specific disease during a given period of time times 1,000 over the population at risk during that period. Unlike crude rates, we are using mid-year population, right? Here, we are saying population at risk. The reason is that it's not everybody is at risk of a disease. There are some diseases or some variables you say is everybody at risk. Maybe if you're talking about crude death rate, everybody's at risk of dying, everybody, because it's universal. That's why you use a mid-year population of everybody. But when you say incidence of measles, for instance, it's not everybody. Everybody is not at risk of contracting measles. For instance, who is not at risk? All those people who are immunized, they are not at risk. You see, so for us to calculate the incidence rate of any particular disease, we look at the number of new cases of that disease among those who are at risk of contracting that disease. Those who are at risk of contracting that disease. So that is how it is calculated. New cases of disease. For example, if there are if there had been 900 new cases of a disease in a population of 250 in a year, the incidence rate would be 950 over 250 times 1,000. If you calculate it, will give you 3.6 per thousand per year, or 36 per 10,000 per year. If you remember, I told you that it's either 100, 1,000, 10,000, 100,000, round figure. You see, when you say number of new cases, it's difficult for you to convince any person that there are 3.6 new cases. The cases are individuals. There cannot be 3.6 individuals. So instead of saying 3.6 individual per thousand population per year, you can say 36. That is, you multiply both sides of the equation by, add 0 or multiply by 10 on both sides of the equation. 3.6 per thousand is the same thing as 36 per 10,000. And it's the same thing as 360 per 100,000. Okay? And the same thing as 3,600 per million. That's just what it is. Simple arithmetic. So, however, note that incident rates must include the unit of time used in the final expression. If you write 3.6 per thousand, this will be incorrect. The correct expression is 3.6 per thousand per year. Once it's coming to incident rate, because remember we talked about rate having the numerator, the denominator, the multiplier, and the time specification. Now, second thing to note, it is not influenced by the duration of disease. Rate is not influenced by the duration of disease. Incidence, is not influenced by the duration of disease. The use of incidence is generally restricted to acute conditions. Acute conditions. Chronic conditions, the incident rate, most chronic conditions are non-communicable diseases. Most times, you hardly find the incidence rates. And I told you yesterday that by convention, the day you made the diagnosis, that is the day you say the disease has started. And you and I know, and that is not very correct. So what are the uses of incidence? It is useful in monitoring disease control, including epidemics. Incidence is very important in public health control. Is the most important yardstick with which we monitor our control program. For instance, when you say HIV control program or malaria control program or neglected tropical disease control program. So for us to know whether the control program is working or not, we'll be tracking disease incidents that control program is addressing. If, for instance, we say malaria control program, then we'll be tracking malaria incidents, that is new cases of malaria. And if we are seeing new cases of malaria when we are implementing a malaria control program, then we automatically run into the conclusion that our control measure is not working well, because despite our efforts, we are seeing new cases of the disease. The same thing with HIV. If we are seeing new cases of HIV when we are doing our HIV control, so we use it to monitor our control programs. Then it is useful in medical research to determine the etiology and pathogenesis as well as distribution of disease. We also use incidence of disease. Remember, yesterday we talked about the natural history of disease, okay? Natural history of disease. So when we follow and know the way these diseases emerge, we are able to know what pathogenesis take place, okay? We can also know how distributed the disease is. maybe in this local government area, we have seen so new cases. In this local government area, we've seen so new cases. For instance, when we were controlling COVID-19, and we were tracking it in all local government areas. And so in Eche local government, we have seen 2 cases, confirmed cases. In so cases, we have seen 2 new cases. In maybe Andoni local government, we see 1 case. In Port Harcourt City, we've seen 5 cases. So based on the number of new cases we are seeing in different places, we know the distribution of the disease and how severely certain areas are affected. Okay. Then 3, we can use it in measuring the efficacy of our preventive and therapeutic measures like vaccines and specific drugs. If we are giving vaccines for a particular disease and we are still seeing new cases of that disease, it is possible that that vaccine is not as efficacious as we might think. All right, now let's go to the second term, prevalence. So the term disease prevalence refers specifically to all currently existing cases, both old and new. If incidence rates are talking about new cases, if incidence rates are talking about new cases, prevalence rates is talking about all old and new cases at any given point in time. So if we go into some area, maybe you go to a particular section of the city and we want to measure the blood pressure of the people in that area, we want to see the rate of hypertension among people in that area, for instance. All we can do is to just measure, use our sphygmomanometer and measure their blood pressure rates. Okay? But as we measure their blood pressure rate, we don't have information when their hypertension began. Whether they are old, their hypertension is as old as 20 years, or the person has just been diagnosed, or maybe our measuring was the first time the person ever knew he was hypertensive. So here, prevalence measures every case, old and new, all put together at any given point. So when we are doing prevalence studies, we just measure, all we want to know is that so percentage of these people are diabetic, so percentage of these people are hypertensive. We don't know when the hypertension began, whether they are old cases or new cases. If we want to now begin to know that, we'll now begin to ask questions, for instance, for how long has the person known that he's been hypertensive and things like that. But if we just measure the blood pressure, we don't have that information. So a broader definition of what is the total number of all individuals who have an attribute or disease at any particular time or during a particular period, divided by the population at risk of having that attribute or disease at that point in time or midway through the period. Well, these are all grammar, but you understand what I mean. It's just that all those cases that have the disease, old and new, at that given point in time, all the people old and new who are at risk of that disease, okay? For hypertension now, everybody's at risk. Even children are at risk, okay? So hypertension does not affect only adults. It's rarer in children, but children I've seen a 2-year-old with hypertension. I have seen in practice. Okay, now prevalence has types. There are 2 types of prevalence rates. We have what they call the point prevalence and the period prevalence. In practice, though, we use more of point prevalence. In practice, we use more of point prevalence, but there is period prevalence. So let's look at them. Point prevalence of a disease is defined as the number of all current cases, old and new, of a disease at a point in time. in relation to a defined population. The point in time here, or in the point prevalence, may, for all practical purposes, consist of a day. All cases of new or old cases are diagnosed in a day or just within several days or even several weeks. If you occur within several days or several weeks, for practical purposes, we still consider it as a point prevalence, okay? Depending on the time it takes to examine that population. Because assuming you are measuring the blood pressure of people in a subsection of a city, it might take you 2 weeks or 3 weeks, depending on how number of persons you are, or even a month to complete. You still call it point prevalence. It's not a period prevalence. What made it longer was because you are going little by little. You didn't have enough personnel or not, things like that. So point prevalence given by formula is the number of current cases, old and new, of a specified disease existing at a given point in time over the estimated population, at risk of that disease at that time. Point prevalence can be made specific for age. It can be made specific for sex, depending on what you want. You might want to know the prevalence rate of hypertension among women, or among men, or among people 65 years and older, and things like that. Whichever way you want is possible. Then let us look at the period prevalence. It's less commonly used, okay? It measures the frequency of current cases, old and new, existing during a defined period of time. Example, annual prevalence expressed in relation to a defined population. Okay, annual prevalence is a longer period, a longer period of time. So it is a period prevalence, unlike point prevalence. Okay, so period is given by the period prevalence given in the formula. Sorry. Number of existing cases, old and new, of a specified disease during a given period of time. Estimated mid-interval population at risk of that disease. Because we talked about long period of time, so we are now taking mid-year interval because it's a long period of time. A lot of movement can take place, but within 1 month, those ones is not much, so that is why. So now let us look at the relationship between incidence and prevalence. A relationship exists between two of them, incidence and prevalence. The prevalence depends upon two factors. Prevalence depends upon two factors. That's why there's a relationship between them. Prevalence depends, one, on incidence. Prevalence depends on incidence. Remember, prevalence is old and new cases. Incidence is new cases. So if we have more new cases coming up, we will have more prevalence rates. Remember, incidence, new cases coming up. Prevalence, old and new together. So if new cases are increasing, it means inside the prevalence, the new cases are increasing. As incidence is increasing, prevalence is also increasing. Okay? Then another thing is duration. If the duration is getting longer, duration of the disease is getting longer, the prevalence is also getting longer, increasing. So prevalence depends on two things, duration and incidence. Okay, given the assumption that the population is stable, assuming we say the population is stable, and incidence and duration are not changing, the relationship between incidence and prevalence can be expressed by this formula. P, that's prevalence, is equal to incidence times duration. Prevalence is equal to incidence times duration. There's a way it can be illustrated. You will see it too, graphically. I'll show it. Now, if the population, for instance, is fairly stable, If disease incidence, say 10 cases per 1,000 population per year, if the duration of that disease is 5 years, that disease takes 5 years, then the prevalence will be 10, that 10 cases times 5, okay, will give you 50 per 1,000 population. 50 per 1,000 population, because the duration, each of those cases will last 5 years. That is why it will not be 50. Conversely, if it is possible to derive incidence and duration as for, it is possible to do it this way, you know, because it's an equation from your basic mathematics. If P is equal to I times D, then in fact you can find what I is. Simply, incidence is P over D, prevalence over duration. Okay, if you put the prevalence over the duration, you get the incidence. For instance, now when you put 50 over 5, which is the duration, you come back to 10. And duration, the same thing can be prevalence over incidence. You get duration. Though these are little manipulations you can, from that equation. So this equation shows that the longer the duration of disease, the greater the prevalence. Any disease that can stay long in humans without resolution, particularly those non-communicable diseases that don't have absolute or complete cure. For diseases that can be easily treated and cured, right? Because you cure them, you are no longer counting them, they are no longer disease cases. But because you're unable to cure them, every year more cases are coming, the old ones are not being cured, right? Say like hypertension, because medically, orthodox medicine, let me say all the way we know, because some people will tell you that either in their church or in their herbal home, they cure hypertension completely. We can't claim that. We say it can be managed. So new cases are coming up. The old ones are being managed, even though they are controlled, but the people are still hypertensive. So for diseases with long duration, their prevalence rates are usually high because new cases are coming in, old cases are just being managed. Only few are dying. So the prevalence will be high. Okay? So for example, in diabetes mellitus, DM, has a high prevalence rate relative to incidence. Okay? This is because new cases of tuberculosis keep cropping up throughout the year, while old ones still persist for months or years untreated. New cases of diabetes, sorry, it's a mistake I typed there while I was typing. So it happens. But some diseases that have acute either diseases that don't have long duration. I told you that diseases with long duration, the incidence rates are usually high because we're unable to cure the existing ones. New cases are joining it. So the incidence will be big. But acute diseases, those diseases that are curable, you can cure them outright, and when you cure them, they no longer contribute to the incidence. Or those diseases where the people die outrightly, prevalence rate is very low. So on the other hand, if the disease is acute and of a short duration, either because of rapid recovery or death, because short duration can be rapid recovery, can be death, the prevalence rate will be relatively low compared to the incidence rate. See, in some diseases, example, food poisoning, Lassa fever, the disease is so short-lived, there are no old cases. The diseases are short-lived. You hardly see old cases of food poisoning. because the food poisoning is cured outright, so you don't see old cases. So incidence rate in them is almost zero. The same thing with Lassa fever. You don't see old cases. The incidence rate is almost zero because you find incident cases where the disease is dragging. Okay, so now look at that. Try to view this illustration, whether you understand it better through this. Incidence, see this tap has new cases, new water is pouring in, and that's new cases of disease entering. This is the other one is the prevalence. Okay, this is the prevalence in the pot, more or less. So look at this place. Here, people are either dying or are recovering. If we close it, which means people are recovering. So if people are recovering, or in a case whereby, okay, they are recovering, they are not dying, like in hypertension, they are controlled. They are controlled, they are not dying, they are controlled. New cases are entering, the incidence will be going up, will be increasing. But if maybe it may be a case of Lassa fever or acute diarrhea, whereby immediately you, if with disease where people are dying, for instance, as they are dying, incidence will be very small because the wider this place is, the whole thing will pouring out. The prevalence, will be very small. Because now if you look at this, if you widen this gap in such a way that you will find that this pot will be empty. Empty. If you widen this exit here, this pot will be empty. That's just what it means. If new cases either lead to death immediately or recover, because if they completely recover, they are not part of the disease anymore. In that case, the prevalence rate will be small. Okay, uses of prevalence. Prevalence help us to estimate the magnitude of either health or disease problem in a community, in a society, and identify potential risk, high-risk populations. It will help us not only identify the magnitude and which populations are high risk. We can do that through the use of disease prevalence. All right. Then we can also use prevalence rates for administrative purposes, for planning, for resource allocation. Because a particular disease is high in a particular area, we might want to set up more health facilities in that area. We might want to deploy more healthcare personnel in that area, procure more drugs or whatever. So for planning and execution, we use it incidence rates to plan. Okay, now let us look at measures of mortality. We talked about morbidity being either disease or, or departure from health, disability. Mortality is about death. Mortality is about death. So what is mortality? It refers to the number of deaths, particularly on a large scale in a population or geographical region area that is being studied. It's expressed in terms of death per thousand population of people. So why are mortality rates studied? Why do we study mortality rates? One, mortality rates are studied to know the prevalent causes of death among the population. So when we know the particular number of deaths, when we see the number of deaths in a population occurring because of one particular reason, then we are most likely to know what to do in terms of intervention. That is why it's very, very important. Then, once identified, scientists could make the general public aware. So if we know that people are dying from any particular days, then we can communicate to the, people and tell them preventive measures and all that. Okay. Also, it help us to take a look at the quality of life of our people. If people are dying, we begin to look at the quality of life. Why are they dying? Okay. So the accurate measure and estimate of mortality levels or mortality trends or causes are different. They are different. So the preferred sources of mortality data, usually mortality data we get from either civic registration, that is maybe from national population, where we do registration of deaths. Okay, we can also through our health facilities, and those ones even in communities are encouraged to, even if somebody dies at home, he's supposed to report to the health facility and death certificate to be issued, for civic registration. But in many countries, especially those with poorly developed statistical system and higher levels of mortality, retrospective measurement in household and surveys is the vehicle they use. Where we're unable to do real-time registration of deaths, we begin to do survey and go and, with time we go to places and ask, in the past 1 year or in the past 5 years, how many people have died in your family? Just trying to get in retrospect what happened in the past. Okay, we do that also, but like now in Nigeria, because of our own National Population Commission, we do real time. All forms of data collection, of course, they suffer from some sort of error, either incomplete data or dating error, particularly if it is retrospective. People may not remember very well, they can give you a wrong date. So let us look at the types of mortality rates. There are many. Crude death rate, age-specific death rate, maternal mortality ratio, mortality in early life, proportional mortality by cause, proportional mortality by age, specific cause, and so many. So I have put all here, but I will jump some of them because in practice, you don't need all, but you just have to know it. Let it just be that you have an idea about what it's doing. So crude death rate is defined as the total number of deaths in a calendar year per 1,000 mid-year estimated population, approximately the average population exposed to risk of death during the year. Okay. The total number of deaths registered over P is your mid-year population. We talked about this mid-year, 1st July, and the constant, right? The constant, either 1,000 or more. Okay, so advantages, we use crude death ratios, the level of mortality in the entire population, usually index of mortality found in our general statistics. Even where a detailed analysis is contemplated, crude death rate often gives a preliminary indication of the level or trend of mortality. Delimitations. It mixes together all population groups, whose mortality varies widely, whereas majority result of mortality study have come from examination of those in different, from different components. So the major limitation is that it combines the mortality of everybody, old, young, sick, well, sick from different diseases, dying from heart attack, dying from cancer, diabetes, heart disease, whatever. Those mix is a problem. It doesn't help us even in planning, because it's so much mixed up. It's not teased out. You see, because it's not teased out, it becomes difficult to use it. It mixes everything indiscriminately. So weakness for international, you cannot use, not even for even local comparisons. You can't use comparison. You remember I told you when you say 15 persons per thousand, 15 per thousand in River State and 12 per thousand in Abia. You can't really compare it. We don't use it for comparison. You can't. If you want to do comparison, you must standardize those rates. That's only when you do it. Okay. Then age-specific rates, better. So this one is the death of population, either particular age group during a year. You see, here you can say death of people under 5 children, neonatal deaths, and things like that. So here, age-specific death rates or age death of any particular group according to age. So it's advantageous to prepare those rates separately for males, for females, age and sex-specific deaths. The only mean of calculation of age-specific death that is unaffected by age the only mean of calculation of age-specific death rate is unaffected by the age composition of the population. Now look at example of specific deaths. Age-specific deaths, for instance, specific deaths in age group 15 to 20, number of deaths in age 15 to 20 over the media population. At times, specific death rate, you use it for many reasons. Use it for many reasons because it's important for our demographic data. If age-specific death rate among young people begin to get high, the society begin to look at things like accidents, things like drug use, and all that. So, or age-specific death for TB and all that. So, these several examples of age-specific deaths. Specific death due to TB, specific death due to for males, specific death for so various age groups. So you can look at that. Then you see maternal mortality ratio. The number of define the deaths of women while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of the pregnancy, from any cause related or aggravated by pregnancy or its management, but not from accidental or incidental causes. So maternal mortality ratio is any death that is related to that pregnancy or conditions associated with that pregnancy, not death from violence or accident or any other thing. Okay. So the risk of maternal mortality ratio, say risk of dying from causes associated with childbirth is measured by that maternal mortality ratio. So this is that definition that's expressed. Now look at this. See this slide well illustrates. I got it from one of your books I gave to you. I like it because it's pictorial illustration of maternal mortality ratio and maternal mortality rate. You see, now look at maternal mortality ratio. The numerator is maternal deaths, right? And the denominator is live births. You see, that is why it's a ratio. The numerator is not part of the denominator. So here, the numerator is maternal deaths, and the denominator is women of reproductive age. You see, women of reproductive, these deaths among women is from these women of reproductive age. So the numerator is part of the denominator. So this book very much illustrates it very well. Then there are other mortalities in early life. These ones will be better for clinicians. So what, maybe, I don't know, since you came here wanting to study, this one will be better for clinicians, like stillbirth rate, perinatal mortality rate, early neonatal death, late neonatal death, all forms of neonatal death, then post-neonatal death, infant mortality. But for you, what is most important is the infant mortality rate, because in public health, we use infant mortality rate and neonatal mortality rate. These two, infant mortality rate and neonatal mortality rate, we use it to look at the socioeconomic conditions of the country. It affects So look at infant mortality rate. Mortality rates among infants. Who is an infant? So you can see who an infant is. From the time of birth to when the person is 1 year is an infant. Many times we just mention this thing without us knowing the details. Or who is a neonate? Neonate is somebody from the day of birth to 1 month. That's a neonate. Okay, so infant mortality, neonatal mortality is important for us in public health. The other ones, the clinicians can look at the rest. So infant mortality rates, so it's a mortality among infants, and it's of special significance, one of the most sensitive index of health conditions of the general population. So if we want to measure, it's one of the measures we use to tell about health conditions of a country. So if you want, there's no way you can write the profile of Nigeria without mentioning the infant mortality rate or under 5 mortality rate. It's not possible. If you do that, the health profile of Nigeria is not complete. It's the most important sensitive index we use, infant mortality rate. So how many children are dying before the age of 1? Because it tells a picture of the healthcare system of the country and the social conditions of the country. While neonatal mortality rate tells more about the health system, the infant mortality rate tells about both. Okay? So infant mortality rate is calculated as the ratio of the number of deaths of infants under 1 year of age to the number of live births occurring in that given year. Okay, that's infant mortality. Then you have one. These are the methods you calculate them. These are the methods you calculate infant mortality rate, infant mortality. So the number of deaths, children under 1 year among the population of that particular area over the live births, okay? Infant mortality rate. Then the significance of our infant mortality rate. The significance of infant mortality rate. It is the most single measure of health status of a population. It is the most single measure of our, of our population, the most single measure of our health status of any country. Infant mortality rate may be very high in countries where health and social services are poor. So if our infant mortality rate is high, we know that health and social services are poor. The other one is neonatal mortality rate. It's the deaths between the age from birth to 1 month to 28 days is classified as neonatal mortality rate. Okay? Neonatal mortality rate is related to problems arising during pregnancy. Example, if there's congenital abnormalities, low birth weight and all that. It can happen where there are birth injuries, asphyxia. That is what I'm talking about, our healthcare system also. Or after delivery, things like tetanus or other infections. When the healthcare system is weak, You see things like children getting infected at the point of delivery. So here it talks much about our healthcare system. Okay. Then the rest, post-neonatal mortality rate, well, these ones, post-neonatal mortality rate talks about, just like infant mortality rate, gives you about the health conditions of the country, including environmental factors, poor child care practices by parents, lack of access to health care. So those are, then perinatal mortality, that is around birth, okay? Mortality around birth. Those ones tell us more about the quality of our healthcare system. Are we able to diagnose fetal distress? Are we able to do something? Do we have neonatologists? How developed is our neonatal medicine? In fact, let me shock you, I only know one trained and qualified neonatologist let me not Port Harcourt now, River State, a neonatologist. All right, these ones I told you is better for a clinician, but you can just read it for your interest sake. Case fatality, I told you we use it to measure disease severity. And case fatality is number of deaths assigned to a specific disease over the number of cases of that disease. Okay, this is another one. This is not popular. It is called by one Raymond Pearl, the ratio of the total number of births to total number of deaths. Okay, or the vital index. For every birth, how many deaths? And, we also use it to look at the level of development on our reproductive healthcare services. The woman cannot be giving birth and the children are dying. It talks more about a lot of the weaknesses in our healthcare system. Then under 5 mortality rate too, okay, that one is similar to infant mortality rate. It talks a lot about our healthcare system and the total number of under 5 children in a given year and locality, and total number of live births in that same year. So the variables here that affect it include poverty. Children can die from malnutrition, poverty, poor education of parents, particularly of mothers, availability, access, and quality of health services. Health services might be available or might not be available. And if they're available, do people have access to it? Are they paying out of pocket? Out of pocket expenditure, pushes families to what we call catastrophic healthcare expenditure. When they spend a lot of their income to take care of health and thereby neglecting other things. Environmental risks, including access to safe water, sanitation, and nutrition. Okay, child mortality rate is there. So that's all. Thank you. Okay, let me look at the time I have. I have 30 minutes. I don't know whether I'll use this for questions or I use it to do some other things. What do you think? Okay, so I have 2 hands raised already. Oh, 3 self. All right, Zubairu, Umar, go on, unmute yourself. So please, you can unmute everyone and let them ask questions. Host, unmute everyone. Okay.
Hello, good evening, sir.
Good evening.
Yes, sir. Thank you, sir. So I just
See the problem of omitting everyone.
That's the problem. And when they will not listen, listen to the lecture, they begin to ask me questions. Yeah, now they will not listen to the question. when somebody will not listen to the lecture, I will begin to ask questions. How will you answer? Just put down your hand. I'm not answering your question. John, please. I'm not answering his question. That shows that, look at the type of noise at his background. They want to ask me a question. John, can you ask your question? Beg, no have time for that. Please ask.
Okay, sir. Good evening, sir.
Good evening.
And thank you for that beautiful lecture.
Thank you.
It is explicit enough. So
Thank
I
you.
want to know, you said mid-year population.
Yes.
We use the 1st of July of every year when you are calculating it. Is it also possible for us to use?
So,
I mean, we use, can you hear me, sir? Now, we said the mid-year population, when you are calculating it, we use the 1st of July of the given period of a given year in calculating it. I want to know, is it also possible?
Hold on, your network was breaking, so I didn't get the whole question. No? Can you repeat it now that it's better?
Okay, sir. I mean, in your explanation, sir, you said when you are calculating mid-year population, you make use of 1st of July of a given year, particular year.
Yes.
Is it also possible we make use of the 1st of January of a year and the 1st of December, you multiply it together and divide it by 2? Can we also use that formula, sir?
Don't use 1st July. The 1st July is a global assumption. When you introduce your own, you have spoiled something. I am not the one that introduced 1st July. It's what is adopted globally. Do you understand? So it is something in science, in public health, has been recognized. WHO, everybody, so don't deviate from it. Except you are such a scientist that with your own this and you convince the world that then before they can change. All right, go on. Next person. Who is next? Sorry. Augustina. Okay, is it Augustina herself? I don't know. Sorry. Is it Polycarp? Polycarp, then because this is changing. Polycarp, Jerry. Go ahead.
Good evening, Prof.
Good evening there.
Please, Prof, I didn't get the explanation of ratio.
Ratio. I'm saying, for instance,
Yes.
if in your office where you work, for every one man, there are 3 women, assuming you have 3 males and 9 women in that section, it means for every one man, there are 3 women. That is a ratio because men and women are different. That is a ratio. For every one white blood cell, there are 600 red blood cells. For every one doctor, there are 5,000 Nigerians. That's a ratio, doctor-patient ratio or doctor-population ratio. Or for every one nurse, there are 15,000 or 18,000 Nigerians, something like that. So that's a ratio. Okay.
Okay, Prof. Thank you, Prof.
Jerry, go on. Okay, if I be, oh, okay. Well, the names are now, there are so many. Jerry, can you go on? If not, okay, let's get Tebepa.
It's not, hello, sir. Jerry is online, sir.
It's okay now, I was calling.
Yes. Concerning infant mortality and under 5 mortality ratio. The factors are there. Can we compare it to child killer diseases? He said one of the factors they are using is poverty, environment, but immunization is not mentioned, sir. Is it part of the childhood killer indicators we can use in the country that a proper immunization has been done or not?
Proper
immunization.
I know, I understand your question. Proper immunization or not is part of health sector. When I say the health sector is weak, a health sector that is weak, maybe there's poor immunization services, poor manpower training, few health personnel, or some health center that open once a week healthcare system. So immunization is going to micro details. There can be health centers that there are no drugs, you know, and so those are just this thing. I don't know whether you get what I mean.
Yes, I do, sir.
One can use healthcare health service, the healthcare delivery service as a whole to cover it. Okay. Immunization is one of the things they do. They also give drugs. They also treat people to give drugs. They also do delivery. If all of them are weak, is the healthcare system is weak. That's what I mean.
Okay. And lack of proper professional manpower.
Yes, they are all part of it. Okay. You know, the health system is made up of the structure, the management, then the processes. The processes, how is it run? How is it managed? You see, so those are all of them.
Thank you, sir.
Thank you. Tebepa. Tebepa, can you? Jesudia. Augustina, can you unmute yourself?
Thank you, sir. Good evening, sir, and thank you for that very wonderful lecture. This is Tebepa speaking.
Thank you.
My question, sir, when you explained incidence rates using measles, you said something about the immunized people not being at risk, and it got me a bit confused. So when we going to subtract the immunized population from the total population, let's say under 5.
Yes.
Are we now going to subtract the immunized population, or we are using that under 5?
No, you are going to remove immunized population because they are not at risk. For instance, somebody who is not flying is not at risk of crashing.
As the denominator.
You only use only people at risk. Only people at risk. So when you are calculating that, you will use unimmunized people only. Unimmunized. What population is unimmunized? That population is the base population you are going to use. Okay, Filet Kunu. Filet Kunu. Okay, Adams Suleiman. Adam Suleiman. Somebody is asking whether can incidence be like point prevalence? No. Incidence is new cases of a disease. Prevalence is old and new, all put together. The old ones, new ones are coming, all existing together. You talk about prevalence. So they cannot be the same thing. Thomas,
good evening, sir.
Good evening.
Okay, so this is Phyllis. Sorry, I'm trying to get clarification. You talked about
perinatal mortality rate and perinatal mortality ratio. Please, can you just a little clarify me on that, the difference? The perinatal mortality rate and ratio. Great. Thank you, sir.
Okay. Let's
Mortality rate. Ratio. The ratio is male to female.
While when you are talking about the rate, you are talking about the severity, it is mild, it is
the number.
The number.
okay.
Totality.
Okay.
Some of them know, now just sabi.
Please, let's have one. The total number of live births.
They know.
Some know.
Please, let's have.
I know that because me, I could look safe. I go through the lecture. Not to I don't understand. So what about? Don't say I will rest my hand. You know, you say Adam.
Please. Let's, Okay, here you have defined as a number of stillbirths. That's stillbirth or late fetal death, and the infant death under 1 week, 7 days. So you have stillbirths under 1 week in the population, total live births, the same population, right? Okay. Now, the number of live births. Okay, this is number of live births, same population in the year. This is number of deaths under 1 week. Oh, this is early neonatal death. Oh, sorry, it's not the same. Late neonatal death, perinatal. Okay, it's just live births, okay? You just take it, call it, is number of deaths, right? Stillbirths and death over total number of live births. That's why it's a ratio. C, stillbirths are dead children. Death under 1 week, they are all dead. Then over live births. Do you understand? Over live births. If it is a perinatal mortality rate, it will be those who died over all the ones that died. So is here, the difference here is stillbirths, that's children that born dead. And those that born alive but died within 1 week. Over all the children born alive, the same period. That's the perinatal mortality ratio. Okay? If you are looking at perinatal mortality rate, as I told you, the rate is the numerator is part of the denominator. So that will be over all deaths. Over all deaths. Okay? Over all deaths. So the numerator will be over the denominator. In fact, I have to leave at 9. I'm sorry, at 7 because I have another meeting. So if you have to ask questions, we'll have about 20 more minutes to do so. Onyinye, Tonyona, Onyinyechi, please ask questions fast.
Okay, good evening, Prof.
Yes, please.
Thank you so much for your
Thank you. Just go on.
lectures.
Thank you very much. Go on, please. Go
Okay,
on.
when you want to calculate death rate,
yes.
When you want to calculate death rate that, okay, when you want to calculate death rate that involves a mid-year population.
Yes.
Prof, please, can you hear me, sir?
I can.
I say when you want to calculate death rate that involves mid-year population, and when you want to do these surveys, let's say sometime in say this year, this month, and we are not yet into the mid-year of July,
Yes.
can you use the mid-year of the previous year to now do the calculation?
Yes, in as much as you can prove that is the media population. The reason is that if you use any other thing that is not media population,
Of the previous year.
yes, if you use anyone that is not media population, it will be faulted because it is something that has been adopted by convention. So there will be questions, yes.
Okay, thank you so much.
Somebody said, is there no time specification for case fatality rate? There is. Once there is a rate, you see, case fatality can vary from year to year. Maybe 100 people got measles, 2 died in 2022. In 2024, 100 people got measles, none died. In 2026, 100 people got measles, 5 died. So the case fatality rate, once it's a rate, there is a time specification. Please. Can we say malaria disease is prevalent? Wait, hold on now. This difference between, I'm not answering the question of difference between incidence and prevalence. You can read it up, okay? You are noise. I don't know, you are in town hall meeting and you put your comment to ask me after I spend my time. Please,
I have a question, Prof. Sir.
Asking me to explain the difference between incidence and prevalence that I've been shouting for 2 hours.
I have a question.
Please go ahead and ask.
Hello, can I ask my question?
Go ahead, I'm listening. Go ahead.
Okay, good evening, Prof. This is Dr. Mari.
Please go on.
Yes. You talked about the fact that illnesses are sometimes only recognized when signs and symptoms become obvious.
Yes.
Now, considering that our situation, the local situation in Nigeria, it's in many cases, a lot of illnesses go unrecognizable until the symptoms are out. So how can this concept of spectrum of health and diseases be helpful? How can it be used to, strengthen maybe early detection or preventive health strategies in our system, in our healthcare system?
Sorry, just repeat. I understand what you have said. The question, how can that from their network?
How can the spectrum of health and disease, which you just explained, how can we apply it to strengthen early detection and prevention health?
Yes, spectrum of health or spectrum of disease is just saying that a lot of disease are unrecognized. Some are mild, some are very severe and complicated. So it's just saying that disease flow in a great range. A range. Some are not even detected at all. Some are mild, others are severe. So it's just trying to tell us how the spectrum, just talking about the linear, if you spread it out, some are severe, some are mild, some are even undetectable. That disease vary across this spectrum. Not all cases of disease are severe. Not all cases of disease are mild. Not all cases of disease are not obvious. So you're just saying that disease spread, it goes across wide spectrum. Some are not obvious to us. Some are mild. Others are severe. That's the spectrum. If you put it in a linear, in a long line, that's just what that spectrum means.
Okay.
Yes.
So how do we make it practical, sir, to maybe strengthen our healthcare system so that,
Now, if you want to strengthen your healthcare system, for instance, those ones that are not detectable, not detected, it doesn't mean because it's not because they are not there. They are there the only way we can detect them is to apply, things like screening. Because one of the ways to detect unrecognized disease is screening. When you screen as I also mentioned along the line, there are many people going about not knowing that they are hypertensive. So when you put that spectrum of hypertension, you can see that there are undiagnosed cases of hypertension, there are mild cases of hypertension, and there are severe cases of hypertension. That's the spectrum of hypertension. So if you want those undiagnosed cases to be recognized in the healthcare system, we need to diagnose, to apply screening tests so that we recognize them. Okay, when we apply screening in our various populations, then we'll detect those who have been going about not knowing that they are hypertensive. Now they have known, and now they are taking measures against the disease. We also treat those who are mild and those who are severe. I don't know whether what I've explained is in line with the, except I'm not understanding the question you are asking.
No, perfect. You've answered well, sir. Thank you, sir. I appreciate it.
All right.
Okay, Prof.
Hello,
Good evening, sir.
Prof. I want
Go
to
on.
contribute something to this of
My name is
Okay, go
Dr.
on.
Maria.
Yes,
Yes,
please
sir.
go on.
She was in terms of helping to discover some of these undetectable diseases. So
Yes.
there are system-based efforts and there are
Course.
patient-based efforts.
Okay.
Yes, yesterday you were talking about modes of intervention. You see, some of this intervention can be patient-based effort, for instance, or health professional-based efforts. When you educate people, you see that that's when we now start talking about health-seeking behavior. You see, the health-seeking behavior of people improve because most of these cases, these people do not appear in hospital. They do not come, and it's when they come that some of these things are assessed. So you see that some of those illnesses, mainly the non-communicable diseases, they remain undetected, and that's the only way. So why there are still health system-based efforts, which is to assess, have the equipment, and making the health services accessible to people. Yes, sir.
I agree. Very correct. Very correct.
Yes, sir.
Health education. I say very correct.
Well,
at times you can see many times you hear that you see somebody doing radio program and you see somebody giving health talk. In our department at UPTH, I remember very vividly, we saw a TB patient, and when we tried to know how he came for screening on his own, and he was diagnosed as TB. And he said he heard about it on a radio. He heard about it on a radio program. It happened that normally we do, where our residents are rostered, they do radio talk. Maybe one hypertension day, somebody will go to some of the radio stations, phone-in program, people will ask questions and like that. So it was a World TB Day, and normally we had that week, we make sensitization. And it was through that sensitization effort that the man is a welder and heard about the radio program and now decided to come for screening, and alas, he had TB. You see, so what you are saying in a nutshell is very correct. Through health education, people can now, also make effort. Maybe what this person explained appeared to be like what I've been feeling. Let me go for checkup. And it turned out to be what the person was. All right.
I also have a question, sir. Sorry.
Please be fast. I'm leaving in the next 5 minutes. I told you people I have
okay, sir. Sorry. When you talked about the types of rates, you talked about crude rate, specific rate, and standardized rates. So what are some of these criteria of standardization? What are these factors of standardization?
Well, we have direct standardization and we have indirect standardization. That's the You know, it's just that I didn't want to bother you, but if you, I can teach you standardization. It's just computational. I will bring a lot of confusion. That's why I didn't bother about it. And I know that most times you might not need it. If not, in fact, it's one of these things I even have, you know, on ground, actually. So there is, you see, let me show you one of this. I have this thing I would have bothered to actually, you know, but I just felt that it will bring us too many. Oh, what's happening? Okay, sorry. So you can see it. There are ways you can standardize rates, but because of I'm looking at the nature of class we have, it's going to bring us a lot of confusion. I decided to be silent on it because many times you might not also need it. You know, if not, I can teach you standardized mortality ratios and all that, but you will ask questions from now till next tomorrow. I know that's the problem. You know, so I felt that I wouldn't need to bother you with it. All right, so that's it. I just deliberately it. Uchechi.
Okay, sir. Thank you, sir.
Yeah. Uchechi Udonsi. James Odo. Okay, I think at this point, I will see you tomorrow. No, not okay. For now, my lectures till next week. I have a few more lectures when I'm coming back from my journey. So from next week, Professor Maduka will come on board, and from Monday. So that's so good night, please. I have another meeting. I have to. It's there. It's like the meeting is at 7. It's called to order. So I'll see you next week. All right, our upper week. All right. Good night. Thank you, everyone. Or if you have your questions when I come next time, please you can ask. You can ask. Just write it down so that you don't forget. I will answer. Thank you and bye.
Thank you, sir.
Thank you so much, sir.